Hello, everyone, and thank you for joining me. I am Shraddha Namjoshi, a doctoral research scholar at the Department of Liberal Arts, IIT Hyderabad, working with Professor Mahati Chittam. And my areas of research interest are pediatric healthcare, psycho-oncology, cancer communication, endocrine disorders, and chronic diseases. And today I'm going to be presenting a study on the unmet supportive care needs of family caregivers of children with cancer in India. The study was published in the Journal of Pediatric Nursing, and the work was led by Mr. Kaputika, Professor Mahati Chittim, myself, Dr. Virendra Patil, Dr. Lauren Kilada, and Professor Claire E. Wakefield. Let me start with why this study matters. So when a child is diagnosed with cancer, it's usually the parents and family caregivers who become the primary decision makers and information seekers, often while juggling financial strain, relocation, and enormous logistic upheaval. We know from prior research that these caregivers experience higher rates of anxiety, guilt, disordered sleep, and emotional overwhelm than caregivers of children without cancer. In India specifically, this burden is shaped by unique factors: social stigma around cancer, fragmented health information, a variety of widely spoken languages, disparities in education and caste, and a common preference for traditional treatments like Ayurveda alongside biomedical care. And despite all of this, only one small study with just 17 caregivers using a non standardized tool has been conducted amongst Indian caregivers. So this leaves a real evidence gap. And our aim was to assess these unmet needs systematically and to see how they related to demographic factors like distance from the hospital, income, and education. So the research design and methods were rigorous and inclusive. And to do this properly, we needed a design that could reach a genuinely representative and often hard to reach population. We used a cross-sectional design with purposive sampling and recruited caregivers by the patient's condition and duration of care. Not just newly diagnosed families, but also families which have been taking treatment for their child for a while. So of the 141 caregivers that we approached, 135 took part, and we continued recruiting until we reached participant saturation. Because many caregivers had limited literacy, we translated and back translated our survey into Hindi and Telugu and read every question out aloud. So caregivers completed the Cancer Needs Questionnaire for Parents and Carers, the CNQ-PC, which is a validated 155-item tool which covers 8 domains with excellent internal consistency at 0.92 on Cronbach's alpha. We analyzed the data descriptively and then used t-tests and chi-square tests to see how demographic characteristics related to caregivers' top reported needs. The whole study was guided by the stroke checklist, and it was approved by 2 separate ethics committees. So whom did we survey and what did caregivers need most? 135 caregivers, or half of them mothers, traveling an average of 292 kilometers to reach the hospital. Almost 70% were educated up to grade 12 or below. And when we looked at the 10 most frequently reported unmet needs, 6 of them came from the feelings domain, which means emotional needs were very high. The single highest need reported by 89% of caregivers was coping with seeing their child in pain, and close behind that, maintaining a normal life at 84%, and getting treatment in their local area and knowing how to support their child, both at 79%. Finally, distance from the hospital compounded unmet needs. We looked at how the distance from the treating hospital affected them, and the pattern was striking. Families that lived further away, some traveling as far as 1,599 kilometers, were significantly more likely to report 6 of these top 10 needs, which included getting access to local treatment, knowing how to support their child, paying for non-medical costs, and maintaining a normal life, as well as coping with their child's pain and feelings of guilt about neglecting the others such as other family members and siblings. In other words, distance wasn't just a logistical inconvenience, it was a vulnerability multiplier. Families who were already furthest from specialist care were also carrying the heaviest emotional and financial load. We also saw that income and education shape which needs go unmet. Caregivers earning 50,000 rupees a year or less were more likely to report unmet needs around feeling anxious or nervous. Those with inconsistent income were more likely to feel scared, and every single caregiver educated to 8th grade or below reported an unmet need for local area treatment access, compared to university educated caregivers who also may likely be more um, urban based, were more likely to have that need already met. Interestingly, we found no difference by caregiver gender, marital status, employment, age, or number of children, or the time since diagnosis. So the picture that emerges is really about geography and socioeconomic status, not so much about who the caregiver is. So what does all of this mean? Firstly, caregivers' greatest needs are emotional, coping with their child's pain, and simply knowing how to support them was a major unmet need. This mirrors findings from other low and middle income countries like Jordan, Indonesia, and China, where formal psychosocial support is similarly limited. Second, geography does have an impact and acts as a multiplier of existing challenges. Families that were traveling the furthest faced compounding, not just additive burden, across logistics, finances, and emotions all at once. And third, socioeconomic disadvantage adds another layer. Lower income and lower education are each tied to specific unmet needs, and these factors likely co occur with rurality, meaning the most disadvantaged families are often facing several barriers simultaneously. Like any other study, this one has both strengths and limitations. On the strength side, we used a validated comprehensive questionnaire. Our verbal multilingual delivery meant that we did not exclude caregivers with low literacy. We recruited from a tertiary cancer care center, but patient footfall was from 6 different Indian states. And most importantly, we included caregivers who were often left out in previous studies: fathers, aunts, uncles, and grandparents, not just mothers. That said, this was a single center study in Hyderabad, so findings may not generalize. Verbal administration could introduce some social desirability bias. The questionnaire itself hasn't been validated specifically for the Indian population, and our sample size, while reasonable, was still modest for a quantitative study at 135 caregivers, which limits our ability to detect more subtle associations. So, where does this leave us? We see 4 clear priorities. Nurses, as the consistent and trusted presence in these families' lives, are well placed to build emotional support and counseling into routine care. Telehealth and community-based cancer educators can help reach families who live far off from the treatment centers, increasing their access. Caregivers with lower income or education need can be identified proactively and supported since they're facing compounding barriers, and ultimately expanding treatment capacity closer to rural and remote communities would directly address the single highest rated unmet need we found, which was lack of access locally to healthcare. In short, caregivers of children with cancer in India are carrying a profound emotional burden, and that burden falls hardest on those who are furthest from care and most under resourced. So, we need to enhance supportive care for these families, not only at the hospital level but also after they return. And it's an essential standard of care that needs to be developed. I'd like to credit the health associated and cooperative and supportive group through which we carry out our research activities. I'd also like to highlight that the article is accessible through the link that we have posted in the description. Our research group consists of various different researchers, academics, and students, and we work in areas like psycho-oncology, psychosocial diabetes care, chronic kidney disease, pediatric diseases, women's health, including endocrinology, behavioral health factors such as diet, exercise, safe sex, and psychosocial aspects of medical technology. Thank you all for listening. We hope that we can present more of our work with you shortly. Thank you very much.